For more than half a century, laboratory medicine has relied on population-based reference ranges as the primary framework for defining health and disease. These ranges have served an important role in identifying overt pathology, yet they were never designed to define optimal physiology or predict functional decline. As a result, billions of patients are told they are normal while experiencing common symptoms such as fatigue, cognitive impairment, memory disturbance, mood swings, metabolic dysfunction, and declining resilience, all symptoms that fall into a biochemical gray zone, being invisible to traditional reference intervals or ranges. This discussion challenges the assumption that statistical normality equates to biological health. As we know, human physiology does not operate in binary states of healthy or diseased. It exists along a continuum of functional capacity. Hormones, neurosteroids, neuroactive steroids, inflammatory mediators, and metabolic signals interact dynamically, and small deviations within the normal range can produce meaningful physiological consequences long before overt disease is diagnosed. Waiting for laboratory values to cross diagnostic thresholds often means a potential of years, since cellular and neuroendocrine dysfunction has already taken hold. Today, we will explore why population-based reference ranges frequently fail to reflect optimal function, and how outcome-based precision physiology models offer a more accurate and clinically useful approach. By integrating longitudinal biomarker trends, multi-system relationships, and patient-reported outcomes, laboratory data can be transformed from static numbers into dynamic signals of resilience or decline. This shift from statistical averages to individualized functional targets represents not only a scientific evolution, but a necessary step toward preventive, regenerative, and truly personalized medicine. A population-based laboratory reference range is a statistically derived interval created by measuring a specific biomarker in a group of apparently healthy individuals and identifying the central 95% of values. In most cases, the lower limit represents the 2.5 percentile, and the upper limit represents the 97.5 percentile of that reference population. Any value falling within that interval is labeled normal, and values outside it are flagged as potentially abnormal. Importantly, this range does not define optimal health, and it does not determine whether the value is ideal for performance, resilience, longevity, or for a specific individual's physiology. Wesley et al. J. Sex Med. 56% of men with borderline but normal testosterone levels had depressive symptoms or overt depression. One of the most common repetitive conversations I have had with patients over the past 30 years is exemplified by this conversation between the patient and their prior conventional healthcare provider. The dialogue goes: the doctor says to the patient, "Your testosterone came back normal at 101 picograms per milliliter." The patient asked, "What is the laboratory normal range?" The doctor responds, 97 to 327 picograms per milliliter. The patient counters, "But I do not feel good at that level." The doctor claims, "If you don't feel good with a normal testosterone level, then you must be depressed. Here have an SSRI." An unfortunate conversation that we now know is more common than not. Population-based reference ranges were adopted for a very specific and limited purpose. They were designed to answer a single narrow question: is this laboratory value unusual when compared to a reference population? In the context of early clinical chemistry, this approach made sense. It provided laboratories with a reproducible, statistically defensible method to flag values that might indicate overt disease. However, over time, this statistical tool has been misapplied as a proxy for health itself. Population-based ranges were never intended to answer far more important clinical questions, such as whether a value is optimal, whether it is sufficient to support performance, resilience, and long-term health, or whether it is appropriate for a specific individual with unique genetics, stressors, and metabolic demands. Yet in modern practice, these ranges are often treated as definitive arbiters of wellness. This distinction is critical and too often overlooked. A value can be statistically normal and physiologically insufficient at the same time. When clinicians rely solely on population averages, They risk reassuring patients whose biology is already under strain and delaying intervention until dysfunction becomes unmistakable. Recognizing the original purpose and the limitations of population-based reference ranges is the first step toward a more precise, outcome-driven, and individualized model of care. Consider this case of a 45-year-old patient with persistent fatigue, weight gain, cold intolerance, depressed mood, and cognitive slowing. Laboratory testing shows a TSH of 4.3 microunits per liter, with free T4 and free T3 still within the laboratory's population-based reference ranges. By traditional standards, this patient was deemed normal, reassured, and sent home without intervention. From the standpoint of population-based reference ranges, this assessment was correct. The TSH value is not unusual compared to the reference population, and it does not meet criteria for overt hypothyroidism. The laboratory has successfully answered the narrow question it was designed to address. Is this value statistically abnormal? And the answer was obviously no. However, clinically and physiologically, this patient is already demonstrating thyroid hormone insufficiency at the tissue level. Numerous studies show that TSH values above 2.5 to 3.0 microunits per liter are associated with impaired mitochondrial energy production, altered lipid metabolism, neurocognitive symptoms, and increased cardiovascular risk, especially when combined with stress, inflammation, or genetic polymorphisms affecting deiodinase activity. In this context, the patient's thyroid signaling is statistically normal but functionally insufficient. This example highlights the misapplication of population-based ranges as proxies for health. The laboratory value correctly identifies that the patient is not yet overtly diseased, but it fails to answer the more clinically meaningful questions. Is the patient's thyroid hormone signaling sufficient for optimal energy, cognition, and metabolic resilience? Is this value appropriate for this individual's physiology? By relying solely on population averages, clinicians risk delaying intervention until compensation fails and overt disease develops. Recognizing this limitation reframes laboratory data not as a final judgment of wellness, but as an early signal along a continuum, from optimal function to insufficiency to deficiency and disease. This shift is foundational to precision physiology and outcome-based reference modeling. At first glance, this thyroid panel looks acceptable. TSH, free T4, and free T3 all fall within the laboratory reference range, which in traditional practice often leads to reassurance and no further investigation is needed. However, when reverse T3 is added, a different story can and does emerge. The RT3 is elevated and the T3/RT3 ratio is impaired, revealing a classic pattern of low T3 syndrome. This reflects impaired peripheral conversion of T4 to active T3, often driven by inflammation, stress, or metabolic strain. So, while the numbers appear normal, tissue-level thyroid signaling is functionally insufficient, illustrating why population-based reference ranges can miss clinically meaningful dysfunction. It is for this reason that always performing complete thyroid function testing is mandatory for optimal patient assessment and potential treatment. In this recent paper on reverse T3's influence on neuropsychiatric disorders, it was made clear that conditions like depression, anxiety, schizophrenia, cognitive impairment, mental fatigue, and muscular weakness frequently existed prior to the diagnosis of overt thyroid dysregulation, based upon standard reference ranges. This also stresses the necessity of performing a complete and comprehensive functional and metabolic assessment of each patient. Now consider a 38-year-old woman with chronic fatigue, frequent infections, musculoskeletal pain, low mood, and poor stress tolerance. Her 25-hydroxyvitamin D level is 32 nanograms per milliliter, which falls within the laboratory's population-based reference range of 30 to 100 nanograms per milliliter. She is reassured that her vitamin D status is acceptable. Statistically, this assessment is accurate. Clinically, however, vitamin D levels in the low 30s are associated with secondary hyperparathyroidism, increased inflammatory signaling, impaired immune modulation, reduced mitochondrial efficiency, and diminished neuromuscular performance, as well as an association with Hashimoto's thyroiditis. Numerous outcome-based studies demonstrate that patients often experience meaningful improvements in fatigue, immune resilience, mood, and musculoskeletal health when vitamin D levels are optimized to 60 to 100 nanograms per milliliter, well above the threshold for statistical normality. Here again, the value is statistically normal but biologically insufficient. This study demonstrates a clear and clinically meaningful relationship between vitamin D status and Hashimoto's thyroiditis. Patients with Hashimoto's had significantly lower serum 25-hydroxyvitamin D levels compared to healthy controls, and those with chronic disease on levothyroxine had the lowest levels of D3 overall. More importantly, the degree of vitamin D deficiency correlated directly with autoimmune intensity. As anti-TPO and antithyroglobulin antibody levels increased, vitamin D levels declined. Nearly half of chronic Hashimoto's patients were severely deficient, under 10 nanograms per milliliter, compared to just 20% of controls. This suggests that vitamin D deficiency does not simply coexist with autoimmune thyroid disease, it may parallel and potentially contribute to disease activity and progression. While causation cannot be definitively proven, the evidence supports vitamin D as a modifiable immunoregulatory factor. In practical terms, assessing and optimizing vitamin D may represent an important adjunctive strategy in managing autoimmune thyroid disease. Finally, consider a 52-year-old male presenting with persistent fatigue, mood swings, reduced motivation, loss of lean muscle mass, increased visceral adiposity, poor concentration, and diminished libido. Laboratory testing reveals a free testosterone level of 5.2 nanograms per deciliter, which falls within the laboratory's population-based reference range of 3.7 to 20 nanograms per deciliter. He is reassured that his testosterone status is normal, and no further evaluation or intervention is pursued. The laboratory has fulfilled its intended purpose by identifying whether the value lies outside statistically defined limits. Physiologically, however, this patient is experiencing functional androgen insufficiency. Free testosterone levels in the low normal range are often inadequate to support optimal androgen receptor activation, mitochondrial energy production, and downstream neurosteroid activity, including conversion to estradiol and dihydrotestosterone, critical regulators of mood, cognition, motivation, synaptic integrity, and glucose transport into myocytes. In clinical practice, men whose free testosterone is optimized into the upper functional quartiles, often 12 to 18 nanograms per deciliter, frequently report significant improvements in energy, body composition, cognitive clarity, emotional resilience, and metabolic stability, supported by objective markers such as improved IGF-1 signaling, improved insulin sensitivity, and enhanced mitochondrial efficiency. This case illustrates the illusion of sufficiency. Laboratory values satisfy statistical criteria while physiological performance deteriorates. Population-based reference ranges correctly identify the absence of overt disease, but they fail to answer the clinically relevant question: is this free testosterone level sufficient for this individual's functional health and resilience? By relying solely on population averages, clinicians risk delaying intervention until compensation fails and overt disease develops. These two images illustrate the core problem with how we interpret laboratory reference ranges, particularly for hormones like free testosterone. The top figure shows a bell-shaped population distribution. This is how laboratory reference ranges are created, by identifying where the middle 95% of a population falls. In this example, values from approximately 3.7 to 20 nanograms per deciliter are labeled normal. From a statistical standpoint, that's correct, but statistics are not physiology. The lower figure reframes this same data from a functional perspective. At the low end of the reference range, between about 4 and 8 nanograms per deciliter, patients are often symptomatic: fatigue, depression, sarcopenia, visceral adiposity, cognitive slowing, and sexual dysfunction. Yet they are frequently told their labs are normal, and that nothing is wrong. Between roughly 8 and 12 nanograms per deciliter, we enter a zone of biochemical insufficiency. Testosterone is present, but not at a level that optimally supports androgen receptor activation, mitochondrial function, or neurosteroid conversion to estradiol and DHT. Functional sufficiency typically emerges above 12 nanograms per deciliter. And what we consistently observe in outcome-based practice is that patients achieve optimal energy, cognition, mood stability, and body composition in the upper quartile of the reference range, often between 15 and 20 nanograms per deciliter. So the key message here is simple. Reference ranges define what is common, not what is optimal. Treating testosterone or any hormone based solely on population statistics rather than functional outcomes leads to systematic underdiagnosis and therapeutic inertia. Precision endocrinology requires that we interpret labs in the context of physiology, symptoms, and outcomes, not just where a value falls on a bell curve. Overlapping the prior slide's concepts, this slide illustrates the fundamental disconnect between how testosterone reference ranges compare to testosterone functional ranges. The orange curve represents the population-based distribution with values from roughly 3.7 to 20 nanograms per deciliter being considered normal. But this curve reflects what is common in a population increasingly affected by obesity, inflammation, insulin resistance, and chronic stress, not what is physiologically optimal. The blue curve represents an optimized functional distribution. This is where we consistently see functional androgen receptor activation, mitochondrial efficiency, neurosteroid conversion, and favorable metabolic and cognitive outcomes. That functional range clusters higher, roughly 12 to 22 nanograms per deciliter. The key insight is the overlap. A large proportion of patients fall into the lower half of the population reference range, that assumed normal yet remain clinically symptomatic with fatigue, depression, sarcopenia, visceral adiposity, and cognitive decline are common in this zone, but treatment is often withheld because the number does not cross a statistical threshold. Precision endocrinology requires that we stop using population averages as treatment targets. Instead, testosterone and all hormones must be interpreted in the context of physiology, symptoms, and outcomes. The goal is not to be normal but to be optimally functional. As we have seen, the population-based reference ranges were started in 1968 and were standardized in 1994. And the beauty of this reference range standard is that they only needed to use 120 questionably healthy individuals. Just for transparency, I'm being sarcastic here. Non-parametric estimates, in statistics, refer to methods that do not assume a specific distribution for the data being analyzed. It does not anticipate a predetermined data structure model but allows for flexibility in modeling data without relying on fixed parameters, making them useful when the underlying distribution is unknown or cannot be easily identified. In other words, they make things up as they go. In an attempt to justify the use of these reference intervals, this paper describes newer efforts to improve reference ranges by conducting larger, multi-center studies across different hospitals and countries. But the bottom line is that they are still population-based ranges. They are trying to make it more credible. In contemporary laboratory medicine, two distinct but often conflated terms, deficiency and insufficiency, define the difference between proactive care and reactive medicine. Deficiency denotes a state in which a biomarker has fallen below the established lower limit of the reference range, often producing clear, measurable pathology. While insufficiency, by contrast, reflects suboptimal biochemical function that precedes overt disease. It is at this stage where enzymatic reactions slow, receptor sensitivity falters, and tissue resilience erodes, yet laboratory results remain technically called normal. In proactive and precision medicine, this would be the perfect time to start optimizing the patient's health, prior to overt illness. So, ask yourself, is your healthcare provider a deficiency or insufficiency kind of healthcare provider? Do they deliver proactive or reactive care? This slide highlights a critical shift in how we think about the term normal. What we have called low normal or subclinical is not necessarily benign, since these states can carry measurable risks, sometimes approaching that of a true deficiency. Importantly, the data supporting this comes from clinical outcomes, showing real impact on cardiovascular health, metabolism, bone density, and overall quality of life. Rather than viewing health as a simple binary normal versus abnormal cutoff, this supports a continuum model from optimal to insufficient to deficient, where physiology exists along a dynamic spectrum, not fixed statistical boundaries. This slide illustrates an often underrecognized pattern in female physiology: the simultaneous decline of testosterone and estradiol and the systemic consequences that follow. On the left, declining testosterone in women contributes to increased hip and abdominal fat, loss of lean muscle mass, worsening lipid profiles, reduced bone density, rising cardiometabolic risks, and dementia. Although testosterone is present at much lower levels in women than in men, it plays a critical role in maintaining strength, metabolic efficiency, motivation, and sexual health. These changes frequently occur while laboratory values still appear within the normal range. On the right, declining estradiol drives many of the classic symptoms attributed to perimenopause and menopause: brain fog, fatigue, mood swings, depression, hot flashes, night sweats, and joint pain. Estradiol is central to neuroprotection, vascular health, and connective tissue integrity, and its insufficiency has far-reaching effects beyond reproduction. At the center is the patient, experiencing diminished libido and declining resilience, not because of a single hormone deficit, but because the hormonal network is disrupted. Testosterone and estradiol function synergistically, and when both are insufficient, the body shifts toward inflammation, metabolic dysfunction, and impaired repair. The key message is this: women can be biochemically normal and physiologically compromised at the same time. Recognizing and addressing hormonal insufficiency early is essential to precision, preventive, and regenerative women's health. This slide highlights a pattern that is frequently missed in male health: the simultaneous decline of testosterone and estradiol, and the downstream consequences that follow. On the left, declining testosterone drives increased visceral fat, loss of muscle mass, worsening lipid profiles, decreased bone density, and rising cardiometabolic risk. Testosterone is a core anabolic signal, and these changes begin well before levels are considered deficient by laboratory standards. On the right, estradiol, often overlooked in men, plays a critical role in cognitive clarity, mood stability, joint health, and thermoregulation. When estradiol declines alongside testosterone, men experience brain fog, fatigue, low mood, joint pain, stiffness, and hot flashes. These symptoms are commonly misattributed to aging or stress rather than hormonal insufficiency. At the center is the patient, experiencing diminished libido and declining resilience, not due to a single hormone, but because the hormonal network is disrupted. Testosterone and estradiol function as a coordinated system. The key takeaway is this: laboratory values may remain within reference range while physiology is already failing. Waiting for deficiency means waiting for disease. Addressing hormonal insufficiency early is essential to precision, preventive, and regenerative endocrinology. Another important core hormone that is frequently ignored is growth hormone. In this study, they compared the deficient state to an insufficient state and found that they both had clinical consequences of reduced bone density, altered body composition, decreased well-being, cardiovascular risk, and metabolic dysregulation. Again, identifying that the standard reference ranges do not accurately reflect a state of health. The controversy surrounding the condition known as subclinical hypothyroidism, where TSH is elevated and the free T4 and free T3 are both normal, begs the question as to when to treat. According to these authors, when TSH is greater than 10 milliunits per liter, regardless of any symptoms. So, what if the person complains of coarse brittle hair or weight gain, depression, fatigue, elevated cholesterol, dry scaly skin, or loss of the lateral third of their eyebrows when their TSH was at a 7? Since it was not yet above the cutoff of 10 milliunits per liter, and therefore no intervention needed. Right. This article is redundant but stresses the importance of treating subclinical hypothyroidism due to the increased risk of cardiovascular disease, lipid anomalies, and neuropsychiatric symptoms. A few conditions that need early intervention before overt disease shortens your quality of life. Well, I know I am pushing the subclinical thyroid dysfunction thing to ad nauseum because depending on the degree of said dysfunction, atherosclerosis, coronary artery disease, heart failure, and cardiac arrhythmias can be present, increasing cardiovascular and total mortality compared to those with a truly normal thyroid function test. Something worth stressing. This study demonstrates that low DHEAS serves as a stable and clinically useful surrogate marker of chronically suppressed ACTH activity in adrenal Cushing syndrome. ACTH secretion is pulsatile and can fluctuate throughout the day, making single measurements unreliable. In contrast, DHEAS has a long half-life and reflects cumulative ACTH stimulation over time. The authors found that patients with adrenal adenomas consistently demonstrated low age-adjusted DHEAS levels. Importantly, individuals with ACTH-dependent Cushing syndrome maintained normal or elevated DHEAS levels, reinforcing its discriminative value. Clinically, this underscores a broader principle. Chronic cortisol excess suppresses adrenal androgen production, and DHEAS provides a more physiologically integrated signal of long-term hypothalamic pituitary axis suppression. Incorporating DHEAS into evaluation strategies improves diagnostic clarity, reduces mislocalization risk, and enhances risk stratification in cortisol-related disorders. This prospective Massachusetts male aging study followed 1,167 men aged 40 to 70 years over approximately 9 years to determine whether baseline DHEA levels predicted ischemic heart disease. The key finding was that men in the lowest quartile of DHEA had a significantly higher risk of developing ischemic heart disease compared to men in higher quartiles where death due to ischemic heart disease was not present. In summary, this study supports low DHEA as independent predictors of future ischemic heart disease in middle-aged men, reinforcing their potential role as biomarkers of cardiovascular risk rather than simply markers of aging. Reference ranges tell us whether a value is statistically unusual, but quartiles tell us where a patient sits within that range. The lower quartiles often represent biochemical insufficiency, values that are technically normal but functionally inadequate. The upper quartiles, by contrast, are where we more consistently see optimal receptor signaling, mitochondrial efficiency, and clinical resilience. By using quartiles instead of binary cutoffs, we move from asking, "Is this abnormal?" to, "Is this sufficient for this individual?" This approach allows earlier intervention, preserves function, and prevents the gradual slide from insufficiency into overt disease. As an example, this slide demonstrates how we can move from a population-based reference range to an optimized performance-based range using quartile analysis. If the laboratory reference range for free testosterone is 3.7 to 20 nanograms per deciliter, that entire span represents the central 95% of the population. But that does not tell us where physiology functions best. To calculate the second and third quartiles, we use a simple formula. Quartile equals the lower number plus the quartile fraction times the high number minus the low number. The midpoint, or second quartile, calculates to 11.8 nanograms per deciliter and the third quartile calculates to 15.9 nanograms per deciliter. This gives us an optimization window of 11.8 to 15.9 nanograms per deciliter. Over 20 years of the millennium's clinical observation of patients, we have identified that patients within this upper mid-quartile range demonstrate better energy, enhanced cognitive performance, improved metabolic stability, and better androgen receptor activation compared to those clustered in the lower half of the reference range. This slide reinforces the central theme of this presentation: that normal spans a wide statistical range, but optimal physiology often resides within a narrower, functionally defined bandwidth which we believe, based upon patient outcomes, is between the second and third quartiles. When the healthcare industry adopts a second to third quartile optimization model, we will then move beyond simply being within range, and instead target measurable biochemical performance ranges. The real question becomes, which biomarkers truly influence cognition, mood, resilience, and physical capacity? Over a 14-year clinical evaluation period, the Millennium 28-point biomarker panel was developed to answer that question. We consistently observed that neuropsychological, cognitive, and physical performance improved most when key markers were optimized into the second to third quartile. This was seen particularly in traumatic brain injury veterans and professional athletes. Because of the complexity of this data, we created the Millennium Office Laboratory Assistant, or MOLA, a computer-assisted expert system that generates a comprehensive interpretive report and predictive treatment protocol. Together, this model shifts laboratory medicine from disease detection to measurable performance optimization. In closing, the correlations are clear in both the literature and in the responses of each patient. We have found that low as well as low normal levels of neurosteroids and hormones are associated with the poorest quality of health and decreased longevity, if not overt disease. Therefore, we need to move from the population-based mindset to the newest paradigm of optimal performance based upon optimal biochemistry. If you have any questions, please send them to the email indicated at the top right of the screen. Please place the word "question" into the subject line if you want a response. Thank you from Dr. Mark L. Gordon and the Millennium Health Network. If you would like to read the article that this slide presentation was derived from, please go to tbihelpnow.org and look under the Science section. If you would also like to learn more about the 28-point biomarker panel and the software that interprets its results, thereby producing a 12-page report with predictive treatment, please go to the AI software section and read about the Millennium Office Laboratory Assistant. Thank you again for your time. This is Mark L. Gordon signing off, and no, I did not have a sex change or increase my estradiol. I just like Colleen's voice better than mine. My 2 new books, Peptides for Health, are available at the Millennium Health Store as the Medical Edition, white, or the Consumer Edition, blue. Either one is packed with more of the type of information needed to optimize your peptide journey, as well as providing a pre- and post-laboratory testing recommendations. Now that Secretary Robert F. Kennedy Jr. is in charge, we expect to see the return of nearly 20 peptides that were unlawfully taken from us in 2023 being placed in Category 2, which we cannot use. Now they are being reclassified as Category 1, and therefore the potential for health optimization is being returned.